Codeine as a cough suppressant. Codeine sulfate is a Schedule II controlled substance with an abuse potential similar to other opioids, but typical preparations for cough comes under Schedule 5. That means we use a lower dose here as antitussive than that for analgesia. This is a centrally acting drug with a significant adverse effect profile. Analgesic effect is an respiratory is on a respiratory center of the brain to reduce cough reflex. Codeine is a narcotic agent, binds to mu opioid receptors. Remember, opioid receptors are abundant in respiratory control centers that include brainstem. Therefore, narcotics are the most potent antitussive agents. Codeine was considered as a gold standard cough suppressant, but recent evidence-based clinical studies proved otherwise. Keep in mind, we don't have many choices to suppress cough. Therefore, still it is a commonly prescribed antitussive. Patients reported to get a better sleep with this drug. Of course, that is because of its mechanism of action that we are going to discuss in future slides. Indications. When do you use this drug? Short-term low-dose codeine suppress dry cough. It is indicated for chronic cough. You can consider this to patients for the management of prolonged cough. This drug can decrease the cough frequency and severity. Let's look at how this drug works, the mechanism of action. It's a mu opioid receptor agonist. Actually, codeine's two active metabolites bind and activate opioid receptors, the morphine and codeine 6 glucuronide. But for the cough suppression, codeine 6 glucuronide is acting on its receptor primarily. That is an important point to remember. This decreases the intracellular calcium and cyclic AMP level, thus inhibit the action potential at the respiratory center. Opioid receptor agonism inhibits calcium channels in axon terminals, which in turn decreases neurotransmitter release, thus associated with some other adverse effects also. Okay. About the pharmacokinetics, codeine is a prodrug activated in the liver by three major enzymes. These are CYP enzymes, CYP3A4, CYP2D6, and one UGT2B7. Major part of the drug is converted into codeine 6 glucuronide, which is the metabolite mainly works to suppress the cough reflex. That is through this enzyme UGT2B7. Okay, about 70%. Still, about 15% will converted into morphine by CYP2D6. You will see patients with a 2D6 polymorphism. Keep in mind, poor metabolizers are unable to convert codeine to morphine. It's good in the case of cough suppression since morphine has only weak antitussive effect. Patients with a very active CYP2D6 called ultra rapid metabolizers convert codeine to morphine very effectively, which can lead to morphine toxicity, respiratory depression, and death, and all those. So that's an important point to remember in this slide. Then in that case, if it is a known dose of codeine, still it gives an unknown concentration of morphine. Okay, so for the antitussive effect of the cough suppression, codeine's metabolites, codeine 6 glucuronide, is significant. Then in summary of pharmacokinetics, this drug is metabolized by liver. The antitussive effects of codeine is because of the active metabolite, mainly codeine 6 glucuronide. Narcodeine is a inactive metabolite, which is by the help of CYP3A4 enzyme. Then the half-life is about 3 hours and about 90% of the drug is eliminated by kidneys. Then about lower concentration of the drug will be there because if the patient is hepatic, the patient has a hepatic or renal dysfunction. Since codeine is a prodrug and activated by liver enzymes, it is very important to note that you should avoid codeine in patients with a significant liver hepatic dysfunction or liver failure. Okay, and then about the adverse effects. In addition to nausea and vomiting and general GI upset, opioid-induced constipation is the most common symptom in patients. Mu-opioid receptors are one of the prominent one in the GI tract, especially in the mesenteric and submucosal plexus. So codeine can inhibit GI motility. Digestion of food in small intestine is delayed. Decreased propulsive conduction and peristalsis in colon results in constipation. About 50% of the patients report this adverse effect, therefore very important for your clinical practice and board exam. If opioid cannot be avoided, laxatives and high fiber diet should be started simultaneously, but because it is for the cough, for generally for dry cough, it is a short course, so not much, but still constipation is pretty common. The next common adverse effect is sedation. Opioid receptors are all over your brain, so codeine can inhibit multiple neuronal pathways. But once the patient stops the drug, it tends to fade away over time. Physical dependence is also notable. Leads to it can lead to withdrawal symptoms. There is black box warning for this drug. That is a very serious adverse effect. So you need to learn specifically for in pharmacology, you need to learn the common adverse effects and most serious adverse effects. Some drugs specifically have that. This one is one example. So the common adverse effect is constipation. Of course, sedation is common, but constipation is most pretty severe compared to this one. Usually when patient takes during night, they end up in sleeping. About the respiratory depression, that is like really very, it can lead to coma and paralysis, and death. So generally, if it is a low dose, like in non antitussive dose, codeine don't get this respiratory depression, but if it depends. If a patient mixed with other drugs or maybe because of the metabolism, all this, a lot of functional liver, all these factors are depending on this one. Okay, so that is a pretty important point to remember. Another point, codeine and morphine are excreted into breast milk. This is of particular concern for breastfeeding mothers who are ultra rapid metabolizers. We don't want opioid toxicity in the infants. That's a major concern. Okay, and FDA have a contraindication warning. Codeine should not be used in children under 12. Then patients with a severe asthma and a paralytic ileus, you should avoid codeine. You also avoid with the other CNS depressants. This can lead to coma and death. Therefore, do not mix with, you have to advise this to the patients, do not mix with alcohol or benzodiazepine. That can also cause severe respiratory depression. So codeine is really important to note about all these contraindications. Okay, so we were discussing the antitussive. So for the codeine, you have to learn from indication to drug about contraindications, because you need to learn mechanism of action, how this drug works, then the pharmacokinetics, because this is a prodrug, it has to metabolize into active forms. So those enzymes are significant. Then adverse effect, those are very important. Indication just here it is for cough. Okay, so cough suppression. Okay, then we were learning antitussive. First one we were discussing was peripherally acting benzonatate. This is the centrally acting narcotic, codeine. And the next drug, the third one, is dextromethorphan. That is a non-narcotic centrally acting antitussive. We have to learn only three antitussives, so let's look at that.